Things before we get started. We're going to record this webinar, so just an FYI about that. We are muting all attendees and we ask that you stay muted until the end when we do some Q&A. There'll be time at the end for Q&A. You can send questions into chat and then we might ask you to come off mute depending on what the question is. Just another plug for we don't allow AI apps, so please turn those off or don't use those, and then just a little link to the webinar at the bottom of the page. So, gonna go ahead and turn things over to Arthur to kick off the webinar. Thank you, Arthur.
Hi, everyone. I'm Arthur Andrews, occupational nurse consultant here at the Healthcare Authority. I work on the transformation implementation team. That's a lot of things to say that my focus is reentry services. I recognize a lot of people in this group, but there's a lot of names I also don't recognize. So just to give a short amount of my background, I used to be a correctional officer in a former life. So a long time ago, I will say that it was about 20 years ago now. So it was a different time. But it does give me a little insight into, kind of some of the barriers that are there, and some of the trials and tribulations that you guys go through in trying to implement this process. So I also want to take some time to introduce one of my colleagues here, Rachel. If you could introduce yourself, as she's kind of our rTCM SME here at the HCA, and she'll be helping with this presentation along the way with questions.
Yeah, good morning, everyone. Thank you, Arthur. Rachel Favre-Koshin, also a registered nurse here at the Healthcare Authority. I work on a different team than Arthur, but very closely with Arthur, but I'll be helping answer questions today.
Okay. All right, so we'll get started here. Next slide. So just some of our objectives that we're going to talk about today. So we're going to review reentry targeted case management and what are the requirements for reentry targeted case management. I'm going to try to touch on some of the common questions and some of the common themes that we've seen so far as we have implemented and been working towards these cohort 1 facilities, some of the common questions or common themes that we've seen come up as we go along the way. We're going to discuss some example client journeys for rTCM delivery services, and keep in mind that these are kind of examples that we have formulated to give you an idea of maybe what this would look like in certain scenarios. And then, we're going to answer questions along the way and afterwards as well. So we may not be able to answer every question. We may have to take some back. That's, sometimes we get some hard questions that need some follow-up that we need to do some more research on. But we're going to do the best we can here to get you the answers that you need if you have them. So it's a lot of material that we're going to go over here. So we're just gonna get right in. And if those of you have been in a presentation with me, you know that I can talk a lot and talk fast. So I'll try to slow down and try to make sure that we're covering all the high points here. So next slide. So the overview, the next slides are going to cover kind of the requirements of rTCM. So, in the first slide here, this is kind of a visual of, what is reentry targeted case management here, right? So it's first and foremost, this is a healthcare centered service, right? So calling that out because many, in fact, all of you are doing some sort of care coordination now when individuals are releasing, connecting them with some services, community resources, those types of things, that is different than what reentry targeted case management entails. And we're going to go over the exact requirements for that, but just covering that reentry targeted case management is really a person-centered service. So it's not a cookie cutter service that you do the same thing for every individual. It's really tailored for each individual and their needs. Some individuals may have higher needs and some individuals may have no needs, right? So just calling that out, the person-centered is really the important phrase in this slide here, and that it's a recovery focused approach, right? I think we all have the same goal here, is that hopefully we're connecting them to services and getting them in the services that they need to keep them from coming back to jail, right? I worked in the ER for a long time, and it was one of the few places you can say, I hope I never see you again. And jail is kind of one of those places as well. When you see them walk out the front, you hope that they don't come back, and that's a good thing in this instance. So as we go through these later on, as we go through some of this, and even in the requirements, we're going to talk about the intake, the pre-release, the release period, and then we're going to cover some of the post-release. We're not gonna spend a lot of time on the post-release, but we are gonna cover some of the post-release because we want to make sure that we're clearing up some barriers and some issues that have come up, and make sure that we're calling those out. In the blue box below, you'll see many of you have probably heard about the Consolidated Appropriations Act of 2023, which gives an entitlement of services to those who are identified as juveniles in the justice system, right? So as it pertains to reentry targeted case management, the CAA, which you'll hear me refer to that, does provide for 30 days of reentry targeted case management, 30 days prior to release and 30 days post-release. So that blue box is really calling out that if you're participating in the 1115 waiver, that the CAA required activities are subsumed into targeted case management, right? So, the requirements in the waiver are 90 days pre-release, and then in the post-release period, we're going to talk about this, it's 30 days or as medically necessary, as you can see in that last arrow there. So I'm really just kind of calling out that if you're participating in the waiver, it subsumes that CAA requirement for reentry targeted case management. Next slide. So what are the requirements here, right? So on the left here, you'll see that this is a pre-release service. And really calling that out, its clients are eligible. Medicaid eligible clients are eligible for the service in the 90 days prior to release. And we'll talk a little bit about that as well. But the four required components here are the reentry health assessment, which is meant to identify those unmet health needs for substance use disorder, physical health, behavioral health, health-related social needs. Really, it's a holistic approach to the individual's needs, right? What do they need medically or socially to get them connected to services to get them on the recovery pathway here? So, and then the development of a reentry person-centered care plan. The health assessment and the care plan, I really do want to call those out. As we got authority to do the waiver, the steps and what was required in reentry targeted case management was called out and what that must entail. And so there are two things in those requirements that do have licensure requirements, and we'll talk about that on the next slide a little bit, but just pointing that out, that asterisk is there because that reentry health assessment is a comprehensive health assessment that does have licensure requirements in the state of Washington. And that person-centered care plan also has licensure requirements. We'll talk about that team approach on the next slide a little bit, but really kind of calling out those two things, that those are the two drivers of the licensure requirements that we're going to talk about. So it also includes that reentry coordination. I think that all jails are probably doing this now. Jail staff is doing this now. We hear that, probation officers are doing this now. JD facilities are doing this kind of coordination now. This kind of coordination is going on in all of your facilities now. That does not have a licensure requirement. That could be completed by somebody who's not licensed. And I'll kind of go over that a little more in detail in the next slide. But that coordination piece is a requirement, and I think that you're all doing that now. And then that warm handoff. That warm handoff to the post-release care manager, that only needs to happen if that care manager is changing, right? So there's a couple of different ways that you can provide rTCM services that we'll go over. But if that care manager is changing in the pre-release to post-release, then there needs to be some kind of mechanism in place to do that warm handoff. We're talking about a medical healthcare associated warm handoff, but jails do this now. So when I was a correctional officer, when somebody came to relieve me for the next shift, we called it pass down, right? I would go over the workings of the shift, anything that was abnormal, anything that was pending, anything that I felt that the next officer should keep their eyes on or their ears open for. Same kind of thing in healthcare, right? What has been done, what needs to be done, what is outstanding, and what are some things to look out for, right? That could crop up. So same type of thing in a warm handoff. We use SBARs a lot in the healthcare system to do this, but there are other methods to do this as well. It's really that person-to-person handoff to make sure that we're continuing the work and not starting the work over. Um, in the post-release period, going over this just a little bit. I know most of you are probably more interested in the pre-release period, but in the post-release period, if that reentry health assessment had not been completed, then it does need to be completed in that post-release period by whoever that targeted case management is. If the jail has passed off to somebody else, then they're not responsible for that. That would be whoever is responsible for that case management moving forward. Same with the reentry person-centered care plan. If it hasn't been completed, that needs to be completed. And those care plans are kind of fed by those health assessments, right? And then that care coordination. And then calling out again, they're eligible for those reentry targeted case managements in that post-release period for 30 days and longer as medically necessary. Really kind of calling out that the waiver is a pre-release set of benefits. So once the individual releases from jail, their benefits are fully activated and they have full scope coverage at that point. Just calling out that in the post-release period that they are still eligible for that targeted case management, and that will continue in the post-release period. And then also calling out that most facilities are doing some kind of intake assessment that's pretty extensive. And so really that blue box at the top is calling out that, you can build upon what you're already doing. In a lot of cases, as a nurse, I've looked at some of the intakes assessment that are being done, and it's very detailed, and there's a lot of information in that. The individual who's completing that comprehensive health assessment on the individual can absolutely use that information to feed their reentry health assessment. In some instances, it's extremely detailed and it has a lot of information. So I would encourage you to build upon existing processes and look at the processes you have in place with your licensed individuals and say, does this meet the need, or does this inform what you need, across the board? So it could. So next slide. So we talked in the last slide about, because of the 4 requirements that are required in, reentry targeted case management, this is healthcare centered case management, right? So there are some licensure requirements for that health assessment, for the development of the health assessment and the care plan. So this is a list of individuals. It's not all encompassing. It's pretty close though. So we're talking about licensed social workers and registered nurses. There are some mental health professionals that can do this, such as mental health counselors, marriage and family therapists. It's within their scope. It's all listed in the billing guide for rTCM, which is on our website. And I believe that somebody was going to provide a link to that in the chat so that you could see it. Really calling out that it's, one of the things that I think one of the common things that we've heard is, the HCA made the licensure requirements, tough, but it's not, we didn't create the licensure requirements here. We looked at what was required in rTCM in case management here, and that's what drives the licensure requirements, right? So in the state of Washington, there's a certain level that needs to be met to be within the scope to complete those comprehensive health assessments and care plans. That being said, we are encouraging a team model here. It doesn't have to be, for instance, you'll hear me use an RN as an example a lot just because I am one. It doesn't have to be an RN completing every task, right? So I said earlier that you can build upon existing processes. If your intake assessment is comprehensive, as the nurse, I would take that intake assessment and look at it and go, what do I need in addition to this, or do I need any additional information to this, right? I can also delegate tasks to non-licensed individuals or individuals who have a license who doesn't rise to the scope of being able to do this initial work, and create the care plans. And other people can help inform that information. It's really the licensed individual who needs to, ensure that it's correct, and they need to take professional responsibility for what is included in that care plan and that health assessment. I know that LPNs are used a lot in the jail setting. Their license does not rise to the level of being able to complete that initial care plan and comprehensive health assessment, but they can certainly help inform, and they can certainly help carry out, what is identified in that health assessment and care plan, and do the after work, and start carrying out what needs to be done. So that's absolutely something that's within their scope. And like I said, you can use non-licensed personnel, right? So when we start talking about coordination services, if somebody just needs a PC, personal care provider appointment made, that doesn't necessarily have to be an RN or a licensed social worker that does that. It could be somebody who doesn't even possess a license who could make that phone call and set that appointment up. So, and absolutely encouraging a team model here. You could have, for instance, a nurse overseeing a team of individuals, and the nurse is kind of signing off on those health assessments and care plans. As long as they're comfortable with doing that. That's a discussion that you would have to have internally with your staff about what that looks like, how that would work, and what your licensed individuals are comfortable with. I've worked in environments where I'm comfortable with signing off on work if I know that it's true and accurate. But if I haven't, as an RN, I'm responsible for everything that is done under my licensure. So I'm certainly not going to sign off on something that I have no knowledge of. And so just calling that out, that when it comes to licensure, there are things that sometimes those people with the licenses will say, hold on a second here. So all service providers, including in-facility staff participating in the Reentry Initiative, must be enrolled as Apple Health providers in order to bill for Apple Health for pre-release services. So, just calling that out, that, people need to be known, and to Apple Health, enrolled with Medicaid, and, when they're doing, providing those services. So, and that's all going to be depending on how the billing is working. So I am not a billing expert by any means. We're going to cover billing, some high level stuff about billing, though. So next slide. So what does this look like, right? So pre and post release. So in the pre-release period, the correctional facility is the responsible entity to ensure that reentry targeted case management is available and offered to all Apple Health clients. Does that mean that it must be provided? It means it must be available, right? And it must be offered. Individuals have the right to refuse healthcare, so we are not compelling this on anybody. If you offer this to somebody and they say, I'm not interested, then that just needs to be documented somewhere that they're not interested, right? That's not to say that doesn't exclude them from being able to say later on, hey, I'm interested in doing this. I think, we understand that sometimes when people are first booked and they come in, sometimes they're not in that frame of mind to be making that decision or be cooperative. And then, time, kind of settles in, and then, they rethink things, and now they're interested in participating in those services. I worked in the ER for a long time. I saw this firsthand as well. So, just calling out that just because they refuse initially doesn't mean they can't opt in later. So, and making sure we're calling that out. But the correctional facility is the responsible entity for ensuring that happens in the pre-release period. In the post-release period, the MCOs are responsible for providing this to their clients. So if the individual is enrolled in an MCO, then that MCO is already responsible for providing that in the post-release period. And the TPA will be helping the third-party administrator that's coming on will be helping build out the network for what that looks like for the fee-for-service clients who aren't enrolled in an MCO. But for those fee-for-service clients, it could be a community entity, it could be a tribal entity, it could be a number of community entities who are providing that service or the TPA themselves. So, but for those individuals who are enrolled with an MCO, the MCO is the responsible entity in the post-release period. And the reason why I keep calling that out is because we have come across some facilities that are like, we have a community entity that wants to do this in the pre-release period and follow them in the post-release period. And that's okay. That's great for continuity of care, but that MCO needs to be looped in somehow. And then, depending on what that workflow looks like, the MCOs are hands-on or they're hands-off, and but they need to be looped into that somehow. Really calling out here that if they're covered by an MCO, and they're enrolled with that MCO, the MCO is responsible for that. So a community entity cannot bill for that reentry targeted case management in the post-release period unless there's some kind of agreement and contract in place with the MCO, which would need to be worked out between them. So, and then, in that pre-release period, in that 90 days pre-release, for both MCO and fee-for-service clients, just kind of reinforcing the carceral facility is responsible for, developing processes, how this is going to work in their facility, how are you going to offer this to all your Medicaid clients? It could be, we've seen a mix of things, right? Carceral facilities doing this internally with their medical staff, hiring staff to do this, using community-based providers to come in and provide that staff. The MCOs can provide that service, and the TPA can provide that service in the pre-release period. There are pros to that. And just calling out here, one of the main things I want to call out here with the MCOs and the TPAs providing that in the pre-release period is if that is your plan and that is what your plan is moving forward, is you want the MCOs to be providing that service in your jail in that 90-day pre-release period. They need a 90-day on-ramp to be able to staff up, to be able to work with you on what that's going to look like in your facility. How are you going to share data? What is that all going to look like? So not 90 days per client, but 90 days overall, right? So as you work towards your go live on your cohort date, they really need a 90-day on ramp so that they can start those discussions with you on how that's going to look for your facility and to be able to develop those processes. So. Next slide. High overview of billing. As a nurse, I am not a billing expert by any means, but we have seen this as a commonality come up. So rTCM is not a per contact bill basis, right? So every time that you have contact with the individual, it's not submitting a bill for, asking the individual a question, making a phone call for them. It's really a monthly billing charge, and that's really kind of what I want to pull out of here. And there's more information in the rTCM billing guide. And if the fee schedule hasn't been posted, it should be posted very soon. I think last I heard it was supposed to be posted sometime this week. So it should be up. If it's not up, it should be up very soon. The it's a monthly charge, and it depends on the services delivered of which billing code you would submit, right? So there's a billing code in the option one for that initial month of services that includes the development of a reentry health assessment and care plan. Um, and then option two is there's an initial month of service was when only the reentry health assessment is able to be completed, and the completion of a warm handoff. So just calling out that there's in that pre-release period, there's a couple of different codes there, but it is a monthly code. You bill for that monthly code, and then it's not every time you have contact, you bill again. Then there would be another if they're in your facility for another month, then you could bill for another monthly code for subsequent months of service there. So there's more information in the rTCM billing guide, but that has been a common thing that's come up is that it's not a per contact bill. Next slide. Before we get into this, I do see that there's a question in there about specific information for the requirements for a warm handoff. Tamara, what I would say to that is that it's a person to person. It could be phone call to phone call. It could be in person. We are encouraging including the individual where it's applicable and where it's reasonable to do so. Much like in a medical setting, it's always best practice to do pass down from shift to shift at the bedside, right? And include them. It gets better buy-in. It includes them and doesn't, it's not like a prescriptive process in those cases. So it's not always applicable. It's not always reasonable. It's not always possible, right? So we haven't dictated what should be included in that warm handoff, only that it is person to person and it is person centered and you're relaying all that information. It should, like I said earlier, it should be, keeping that continuity of care intact. So the whole point of passing off to the post release is so they can continue the work. So you should be sharing that reentry health assessment and that care plan, kind of what's been done and where that's at. So
Hi, Arthur. Can I interject a minute?
yep.
For the warm handoff question, there are required components listed on page 31 of the rTCM billing guide. And that includes completed consent, the reentry care plan with provider information, and then the status of any outstanding needs or appointments. But again, that can be found on page 31 of the rTCM billing guide.
And then before we move into the scenarios, I see Brooke's question there. Does care coordination have licensure requirements, or can non-clinical people bill for monthly check-ins when the month doesn't include the assessment or plan? Basically, does a care manager need to see the patient every month, or can the non-clinical team member provide the follow-up meeting to check in? That is a very detailed billing question, Brooke, that I'm going to be really honest. Rachel, do you know the answer to that? Because I don't know the answer to that off the top of my head. So,
I am also unsure how it would just depend on how you're trying to or who's billing that. Um,
right,
so I'm not sure how that works with the
yeah,
non-clinical team member.
in order to bill for the service, it would be, the clinical person billing through the provider, right, and providing the service. So we'll take that back, Brooke. Okay, so now we're going to go into some client scenarios. Next slide. So as we're navigating these scenarios, we're going to do a couple of short-term stays, and I think there's one long-term stay in there that could be two, but I think it's one. So we're defining short-term stays as less than 90 days, and there's a reason why we're doing that. We're defining that as 90 days because we understand that there are clients that are in facilities for a very quick turnaround, right? And jails typically don't have release dates. They'll get arrested and booked, and then they'll get released. The arrest and booked on Saturday, they release Monday morning. It's been communicated to us pretty clearly that jails do not typically have release dates. So really that 90 days starts at the time of booking. So, we're going to go over the timelines of the expectations of reentry targeted case management and what that looks like. But just want to call out that that's a common question that we get about these short-term stays. And how do you know when the 90 days starts when we don't have release dates? But that 90 days starts really at the time of booking. And then, if they're in longer than 90 days, there's some systemic things that happens that will, switch that in the system. So just calling that out. The majority of individuals in jails and juvenile detention facilities are incarcerated for a short period of time. It is a big number that are incarcerated less than 90 days. And so, like I said, for those clients, reentry initiative benefits should begin as soon as possible. So for those long-term stays, longer than 90 days to expected release date, for individuals with with a known release date that are more than 90 days out. Benefits should begin 90 days prior to the expected release date in that 90-day pre-release period. We know that this can happen. This is pretty typical in DOC, right? They get transferred to DOC, and then they get that release date, and then they start working on their release prior to their release date. But we know that this can happen in county jails as well. Sometimes people in there longer, they get sentenced to longer than 90 days. So if you know that the individual is going to be in there longer than 90 days, and that should be in there, in that 90 days pre-release. Facility should confirm the individual's eligibility for Apple Health before that 90 days starts, right? In order to bill for services, they need to have that coverage in there. So it's definitely, to your advantage to check that eligibility prior to that 90 days starting, so that there's no hiccups with submitting for bills in that time frame. So just calling that out on those long-term stays. And the short-term stays, the system, if they're already known to Medicaid and already enrolled, that 90 days is going to start at the time of booking. All the adult jails are reporting through WASPEC, which we piggyback on their system to update them in our system. JD is going to be more of the juvenile detention facilities will be more of a manual process, and then DOC also, we have a system in place for them. So next slide. So this is kind of the format that we're going to follow for the client scenarios here. So we're going to talk about the intake process, the pre-release, the release, and the post-release period. Just keep in mind that these are general ideas. Every situation is going to be different. And what looks, things may look a little different for your facility depending on how you're doing it. But what we really did was took the requirements and kind of made some scenarios to kind of give an idea of what this will look like. Next slide. So we're going to talk about common short-term stay scenarios first here. So next slide. This graph can be found in our P&O guide on our reentry website. And really, we're focusing on the reentry targeted case management here and not the other individual things. So what I really want to call out here is that if you look at the box there for reentry targeted case management, as you can see that reentry targeted case manager assignment doesn't need to be done. It just needs to be done within the first 48 hours of the individual's booking. And then if you look across the top there on that timeline, it says hours and business days since Apple Health enrollment, right? These individuals need to be known to Apple Health. So if they're already known and they get booked and you report through JBRS, they'll already be in the system. If they don't have coverage, then they'll need help in navigating that process and enrolling through that process. And we're seeing a variety of ways that's happening. But really just calling out that top there is, hours since booking. And then once you get to the days, that's business days, right? So really for reentry targeted case management here, that assignment needs to happen within the first 48 hours. That reentry targeted case management reentry health assessment needs to start by business day 3. And then that care plan and coordination needs to start by business day 4, right? Calling out that the warm handoff here across the bottom, you'll see it's blue, should occur before release and no later than 7 days post-release. We're not calling out the days there because if you arrest the individual and they say they're interested in reentry targeted case management, maybe they release before you could start this, right? So maybe they were you booked them on Saturday, they said they were interested, you forward it off to whoever the reentry targeted case management is going to be for your facility, whether that's internal or external, and then they release first thing Monday morning when they go to court, right? You didn't even have time to get the business day 3. You may still need to do that warm handoff with whoever's going to be doing the post-release, just to let them know, hey, they discharged before we were able to start anything, so that post-release care manager can then pick it up from there and try to contact the individual and get them going. So next slide. So let's talk about the first scenario here. So the first scenario here is a guy named James, 28-year-old male with substance use disorder issues. It's expected that he's going to be in jail for a short amount of time. Release date's unknown, which is pretty common in these situations, and he's in a jail. The rTCM model is that it's going to be in reach, meaning it's going to be somebody from the outside coming in to do that. And in this case, it's going to be the MCOs providing that service for the jail because they've determined that's the best way to go for them. And they work that out with the MCOs. And then they're already enrolled in Apple Healthcare. So they're already known, they're already enrolled with an MCO. So next slide. So the intake process here, right? So James comes into the correctional facility with an unknown release date. The correctional facility is expecting James to have a short stay and expecting him to release pretty quickly. So in alignment with that short-term model, the correctional facility is going to need to check that eligibility, right? There's going to need to be a mechanism in place to do that, and verifies that he's already enrolled and known, and he's already enrolled with an MCO. So the correctional facility conducts the reentry health screening, right? This could be your typical intake screening that you're doing, and then during that time he reports he's taken buprenorphine for SUD, and that he does express interest in that time during that booking process that he's interested in an rTCM case manager. I do really want to call this out because there is some terminology confusion sometimes between the two, between corrections and healthcare, right? So really what we're talking about here in this reentry health screening, we're not talking about the comprehensive health assessment that's going to be done by the licensed individual. We're talking about your normal intake process. How are you screening these individuals for their medical needs, and how are you screening them for other issues as they come through your intake process? That's what we're talking about here. What we're seeing is most facilities are working, this kind of work into that already process that already exists, building upon their existing processes, right? Not building a whole new process. So just calling that out. And then because he has SUD issues, they're scheduling a same-day appointment or using the provider on call to ensure that that medication for MOUD can continue. That is, calling that out. SUD treatment is a requirement within that first 24 hours and that continuity of care. We're not covering that today in detail, but that was reported during this initial health screening by it could be a correctional officer who does a health screening. It could be your medical staff. I think I've seen a variety of ways that initial intake screening is done, but just calling out that if they report SUD treatment, then that needs to be addressed right away. So. Next slide. So the pre-release period here, the correctional facility staff contacts the MCO to assign the rTCM care manager. This could be different for every facility. Like I called out earlier, if you've identified that you want the MCOs to provide that rTCM service, the MCOs and the TPA to provide that service in the pre-release period, you would need to work with them individually and work with all 5 of them individually, or 6, including the TPA, to figure out a process for how that's going to work. And so, just calling that out, that could look different from facility to facility. And then, that rTCM care manager would conduct a visit with James at, where they would complete that reentry comprehensive health assessment here. Now, I say conduct a visit. I'm going to say here that telehealth is going to play an important role here in this environment, I think. So, that just calling out that, conducting a visit could mean a telehealth visit, it could be audio, it could be those things. So. And then the MCO rTCM care manager confirms that James is in fact taking buprenorphine and is planning to reside in the county he's incarcerated in after release. And that's when, on day 3, that TCM, that care manager, begins working with James on the development of a reentry care plan. Just calling out here that it says, working with James on the development of a reentry care plan. Care plans are generally healthcare documents that are written for the healthcare professional, and so they're written in a way that's to pass down from healthcare professional. I worked in the hospital as RN to RN, but the reentry care plan is really kind of should be created based upon that comprehensive health assessment. But sometimes when you're creating those care plans, you realize you have a question, so you may need some more answers to some questions. So that care plan should be centered on the individual's goals. I've certainly seen cookie cutter reentry, or not reentry, but care plans where they're kind of the same across the board. Care plans should be patient-centered and goal-oriented, right? These are things that have been identified in the comprehensive health assessment that need to be completed, or they're tasks that need to be checked off the list, so to say. So um, that care manager identifies a local provider who can provide post-release care and medications to James in that time period. And like I called out below in the blue box, that the correctional facilities and MCOs need to develop facility-specific referral processes. So next slide. So on day 4, James is unexpectedly released, right? So he goes to court and he's released. So since James' release took place during business hours, he needs to be released with a medically appropriate supply of medications, which is also a requirement that we're not really focusing on today, but that he would need to be provided a 30-day supply of buprenorphine in hand upon release. So, and then the blue box down there is just calling out, if a client is released unexpectedly outside of pharmacy hours, the facility must offer the client the option of coming back on the next pharmacy business day to pick up medications, or identify a community pharmacy of James' choice for that correctional facility to coordinate and call in for that access to the 30-day supply. They need to have both options there, and that's in our P&O guide. And it's written in there. So just calling that out, that if they're released, we understand that individuals are released unexpectedly. They're released after hours. If they're released during business hours, or it's coming, like they're releasing the next day and you have time, the expectation is 30 days supply of medications in hand where clinically appropriate, or unless the law says otherwise. But calling out that if they're released unexpectedly, then they should be given the option of coming back the next pharmacy business day to pick up their prescription, or if the client chooses to have it called in. So, next slide. I see some questions there. We're definitely going to get to those questions. So, not ignoring you. I think that there's some questions over there that I am definitely seeing. So in the post-release period, the rTCM care manager is going to continue that care for James in the community, right? As his post-release rTCM. In this case, he was seen by the MCO in the pre-release period. He's going to be served by the MCO in the post-release period. So there is no warm handoff that's required there, because that care is not changing. And so the rTCM care manager will review and finalize that reentry care plan, make sure everything's up to date, make sure they're communicating with James. And because he released unexpectedly, it may not have been finished. So, they'll finish the work that was started in the pre-release period. And then, in that post-release, they'll transition out of rTCM as soon as all of the goals are met and it's not medically necessary for them to receive them. So in this case, he needed to be connected with a community provider to continue his buprenorphine. The targeted case manager was able to get him connected there, and then can discharge him from that reentry targeted case management at that time once all goals are met. So, or James says, I don't want this anymore, right? All right, next slide. So here we have a 30-year-old female who's 4 months pregnant. They have not had prenatal care, and they do not have a PCP, and they're homeless. I can tell you, I worked in the ER for nearly 10 years, and I saw this pretty commonly. Their expected length of stay is short. This individual, Nicole, is not expected to be in jail for a long period of time. And this is a scenario that's taking place in a jail. Again, this is an in-reach, but in this case, it's a community care manager that maybe the jail has contracted with to provide those services in the pre-release period. And so they are known to Apple Health in this situation. Okay, next slide. So let's start with the intake process, right? Nicole enters the correctional facility with an unknown release date. And the correctional facility expects Nicole to have that short stay. So again, the correctional facility is going to need to verify that eligibility in Apple Health and verifies that she's already enrolled with Apple Health and has an MCO already assigned. What we are seeing and what I'm seeing commonly is that in these first jails that are kind of adopting in this first cohort, they're working this into their intake process somehow, or something similar to that. And then, as we talked about before, you're going to conduct that reentry health screening, that intake assessment, however you're doing that for Nicole. And at that time, Nicole shares that she has had no prenatal care and is interested in that rTCM care manager in this case, right? So, next slide. Um, so the pre-release period, we're talking about days 3 through 14 here. So the reentry initiative benefits begin, right? So that begins right at booking. They're already known to the MCO. So like I said previously, that first 90 days pre-release period is going to start at booking. And then that reentry initiative benefits will be active at that time. So the community-based rTCM care manager is assigned. However, that's going to work. That's going to look different from facility to facility, and it's going to look different depending on the organization that you may be working with as well. So in this case, Nicole, they set up a telehealth visit with the community-based rTCM care manager, during which they complete the comprehensive reentry health assessment at that time. The rTCM care manager confirms with Nicole that she is pregnant, and her lack of prenatal care or any provider prior to incarceration. And so she additionally shares that she is homeless as well. Right. So at that time, they've identified that she's pregnant. She hasn't had any prenatal care. She doesn't have a PCP, and she's also a homeless individual. So the community-based rTCM develops that care plan with Nicole and arranges for Nicole to see a PCP and an OBGYN in her community upon release. And I will call out that this is probably going to be an easier process than it was previously because I know there were barriers before because they did not have active coverage. And sometimes you'll call, a PCP or a provider and they'll go, well, they don't have active coverage and I need to be able to see that they have coverage in order to schedule this appointment. In this case, they're going to be able to see that, right? So the community-based rTCM care manager connects Cole, also connects her to a community hub that can help her with housing upon release as well. So addressing not just her medical needs, but also addressing her social related health needs as well. Next. So on day 15, Nicole is released from incarceration after court hearing. They arrange to have so that she can have her 30-day supply of any prescribed medications in hand. And at that time, because of the work and the connection that they made with that community provider, Nicole moves into short-term transitional community housing, arranged by the community care hub in her region of residence in coordination. Just calling out that I know I make it sound easy. I know it's not that easy. So just calling that out, but using this as an example of, not just connecting her with her medical needs and setting up that appointment, but making sure that we're addressing her social related health needs as well. Next slide. So in that post-release, the community-based pre-release rTCM care manager will continue to provide support upon release in the community, as they are contracted with Nicole's post-release MCO. So we talked about this earlier, right? The MCO is responsible for the post-release targeted case management, but there are instances we're seeing where community providers are providing that in the community and then continuing to care for them for that continuity of care post-release. That is okay, but that post-release, that MCO needs to be involved in the conversation somehow. And in this case, the MCO has worked with that community provider. They have contracts in place, and so they're able to provide that service after working with the MCO. So The community-based rTCM is scheduling necessary prenatal care appointments and that post-release with that PCP and OBGYN. They're further coordinating with the community hub for long-term housing as needed. And then, Nicole's going to transition from targeted case management as she is connected to the care in the community, is getting that prenatal and eventually postpartum support in addition to addressing any of her other needs. So again, it's about setting those goals, meeting those goals, and calling out that at any time if an individual says, I don't want this anymore, that they have the right to do that in that post-release period or the pre-release period. So next. All right, so we're going to talk about a longer term scenario here. I think this is the last scenario we got. I do see some questions there that we can definitely get into, and we're going to have time to get to here. So calling those out, we're not ignoring you. Um, so let's talk about the next slide here. So now we're talking about longer term incarcerations. This could be a DOC. This could be in a county jail, right? I mean, I know that JD facilities typically aren't keeping people long term. They can, but typically what we're seeing in JD facilities is short term stays and then transferring to JR if convicted for a longer term stay. But DOC definitely has those longer term stays. County jails definitely have these longer term stays as well. So just calling out that this looks a little different in the situation. If you expect that individual to be in jail for a longer period of time, that this is a 90-day pre-release set of benefits. So if they're, say they're sentenced to, a 1 year time frame, then that 90 days would be in that 9 to 12 months before they release, right? And if there's an earned release date that's entered into the system, then the system should calculate that and set up those benefits so that they're active in the system. If there's no ERD, then that's a different conversation. But for the sake of this, we're going to say that we know when they're releasing, right? So in this case, we are recommending that the rTCM care manager assignment should be done prior to the 90 days so that benefits can start at the 90 days, right? If you start providing those benefits, you want to be able to bill for them. And so, making sure that that's in place and ready to go is really to your advantage to do so. And then, in that 90 to, that first month of active, that reentry health assessment should be completed, that care plan and coordination. And then, that warm handoff looks different in this situation, right? If you know when they're releasing, then it should be done, 14 days prior to release, so that and no later than 7 days post-release. So there is a little bit of leeway there, but this is a different situation in which you know when they're releasing, so you have time to plan. Next slide. So in this long-term scenario, we have Franklin. He's a 53-year-old male with hepatitis C. He's expected to be in jail for a long time. His release date is known in this situation, and he is in a Department of Corrections facility. But again, any one of these facilities, any one of these scenarios could be in any facility. DOC has short turnarounds at WCC as well. They have violators that come in and out of their facilities as well. So they have those short-term stays, and those long-term stays do happen in those county jails, and we know that. And so in this case, the targeted case management model is going to be in-house correctional facility staff, right? So the correctional facility has decided that they're going to provide this service themselves, whether that be with their medical staff or they're hiring staff to do this. They're providing it, and that's the model that they've adopted. But in this case, Franklin is not enrolled in Apple Health. And this could be simply because of the time frame he's been incarcerated, or it could be that he just didn't have coverage before he went in. I know that there's a thought that everybody has coverage, everybody has active coverage, but working in the ER, I saw a lot of individuals who did not have any active coverage. So in this case, Franklin does not have any active Medicaid coverage. So next slide. So what does the intake process look like here, right? So this looks a little different because we're not talking about booking. So prior to the 90-day pre-release period, the Reentry Initiative benefits are not yet available beyond 90 days. because we know when the earned release date is. It's in the system. It's been calculated. Benefits are going to activate in that 90 days prior to release. So in this case, the correctional facility is going to conduct their routine activities and processes during this period. They're going to conduct their standard reentry health screenings here in that 120 to 90 days prior to release. We are encouraging that you check their Apple Health eligibility status, and in this case, it's been verified he's not enrolled, and an application assister would need to help Franklin get an application submitted for Medicaid. And that's important because, right, these benefits are only available to Medicaid eligible individuals. So if they don't have coverage, then that application needs to be submitted so that you can get coverage activated for them. So, or find out that they're not eligible for coverage, right? Um, so all activities conducted, that are provided during this period before 90 days are not billable services, right? So just calling that out, that those reentry health assessments, those intake assessments that you're doing are not the billable service. It's once they get to reentry targeted case management and that comprehensive health assessment starts, that's the billable service here. So helping them get an application submitted, it's not a billable service, and doing those routine intake assessments are not billable service. So yeah. So next slide. So the pre-release, 90 days prior to release, at that start of that, Franklin is connected with that pre-release rTCM care manager and is assigned. He is enrolled with an MCO, because we've helped him with his application. We've got him active in the system. He's been assigned to an MCO. He has that visit with his rTCM care manager, during which that reentry, comprehensive health assessment is conducted by that care manager. And during that health assessment, it's determined that and that further coordination with in-house medical teams, it's learned that Franklin has recently screened positive for hepatitis C, right? So they arranged for that care manager, that in-house medical provider visit, who begins treating him for hepatitis C. I know that it looks like here, well, when we know that, I can't count how many times, I was in the ER setting and, we learned different things as different people went into the room. So, they may not always know this, and it could be, the nurse or the social worker or whoever's doing this reentry health assessment learned something that maybe medical didn't know, and it certainly happens. So in this case, during that interview, they discovered that, he had tested positive for hepatitis C, and as part of that case management, made sure to connect him with that in-house case management so they could start that treatment for that, right? They develop a reentry care plan with Franklin around his health goals, and make sure to connect him with a PCP in the community that can address his hepatitis C needs once he discharges, right? To make sure that we start that treatment and continue that treatment, and that there's no break in that treatment once he gets out. So next slide. So in that 14 days prior to release, Franklin will be served by the rTCM care manager through his MCO. So the in-house pre-release, that in-house targeted case manager is going to schedule that warm handoff, and make sure that they're doing that warm handoff with that post-release targeted case manager, so they know what has been done, what is outstanding, and what needs to be done. And we're encouraging that we include the individual in that warm handoff where possible. That's always best practice in healthcare. Again, it's as clinically appropriate. We completely understand that it's not always the right thing to do, or it's not always possible, but encouraging that where possible. During the warm handoff meeting, the pre-release rTCM introduces Franklin to his post-release rTCM. They review Franklin's reentry health assessment, their care plan, and his current medical needs. And the correctional facility ensures that Franklin has his medications in hand upon release. So, connecting them with that post-release is always good, because they know who it is. They're more likely to pick up the phone. They're more likely to talk to them and continue that coordination as it happens. Next slide. And then in that release period, he's released with a 30-day supply of medications in hand. Known release date, right? Known release date, time to plan. He was given that 30-day supply of medications in hand. So next slide. And so in that post-release period, Franklin's post-release MCO confirms that connection with the PCP, just confirming that appointment is in place, confirming with Franklin that he knows about it. And then, once all patient-centered goals have been met, transitions, Franklin out of that targeted case management benefit in the post-release period. So next slide. All right. The next slides are, you can download. There is some references and some resources there for you, such as the provider billing guides and fee schedules, the Reentry Initiative code list. Just I could talk briefly about that. It's the list of approved codes, but it's really a list of approved codes. It's really according to the fee schedules program about, how to bill for that particular code and when and who can bill for that code. There's a link there to provide one billing, wax. There's some EPSDT definitions there, and there's some other benefit resources that I'm not going to go through them all, that you can certainly look at your own leisure following this webinar. There's a lot of good resources. It's a lot of information. Just calling that out, that we're concentrating on targeted case management for the benefit of this particular webinar. So,
Arthur,
yep.
before we get to questions, can we go back to slide 8? We
Mhm.
have a slight correction to make. Thank you. Um, we're under the post-release rTCM. I think specifically the note in that box. It says that the community providers would need to contract with the TPA as well, and that is incorrect. Because the TPA will not be paying for it will not be paying for any services. So for the fee-for-service clients, they would just bill HCA directly, and then managed care enrollees, they would bill MCOs.
Perfect. Appreciate
Thank
that
you.
correction there and catching that. Okay. Um, do we want to just kind of go down the list here of the questions and kind of go through them one by one? Ed, is that the best way to do this? And then either Rachel or I can take a stab at it and see if we can answer it.
That sounds good, Arthur. Let me know if you want me to read the questions out or if you've got it from the chat. Just
I, I
happy to
think
help.
yeah, I think I can do it. So, Brooke, we covered yours. We gotta, that's something that needs follow up. Kittitas County, I see that you say if John Doe shows up for a jail commit for 180 days, can we still screen and enroll right at time of arrival, but not start benefits until day 91? That's an interesting question. That's an enrollment and eligibility question that I'm going to be really honest is kind of out of my scope. I believe you could screen and submit and submit the application for them if needed beforehand, and I believe you can. So um, if somebody else is in here that says differently, please correct me if I'm wrong though. So you should be able to, if you screen them and see that they don't have coverage, you should be able to submit the application for them still. So it looks like, okay, can we have the link to this guy? It looks like Lindsay, you provided it. Thank you. Megan, I see your question there. Business days is Monday through Friday. Is that when the reentry targeted case manager staff is available? I think that's a loaded question. So our requirements are when things need to start. Could we go to that short-term model, Takina? I think it's uh, next slide, I think. Next slide. Next slide. There it is. So really what we're saying here is when these things need to start, right? So So business day 3, within 48 hours, the assignment. Business day 3, that reentry health assessment needs to be done. And then by business day 4. So what we're saying is this is the expectation. How that's going to work for each individual facility is going to be different. They could have somebody who could do this, 7 days a week, and that's okay. What we're saying is this is the expectation of the minimum of when we expect it to be done by. Does that help, Megan? It could be done before that. By all means, if you could do it sooner, that's this. I mean, that's better. That's best practices as soon as possible. So. But when we develop the program, we recognize that there's a lot of fast turnarounds. There's a lot of barriers and a lot of maneuverability that's going on, during the booking process, and those really fast turnarounds can be a big barrier there. So, the next question? Is it recommended that carceral facilities set up all MCO phone numbers so that the inmate can call them directly if needed? Yeah, I mean that's a great way to do that. I will call out that the services, there cannot be a charge for Medicaid services. So we have seen jails that have in their systems. We know there's a cost for phone calls, but made those particular phone numbers free for your individuals to use to be able to call their MCO. It's really however it sets up for your facility and what works for your facility. So, and also, working with the MCOs, right? So that's a collaborative effort, and to come up with a plan that works for both of you. But I'm a fan of allowing them to call their MCOs when needed, because that's, things come up and they can work with them directly. So. So if they are rebooked and then released again within 30 days, would we release them with an additional 30 days of Suboxone? So, Lisa, I'm not going to, we're focusing on the targeted case management here. What I would say is that there are already checks and balances in place for prescription medications, right? The expectation is 30 days in hand, or when it's not clinically appropriate, or when the law says otherwise. For instance, like birth control pills are a good example. You got to provide longer than 30 days if you're going to provide them. If they've already been rebooked and they've already been given a supply, then there's already checks and balances in there for clinical justification, right? So same thing would go if they say they lost their medication. There's already checks and balances in place. We have not removed those checks and balances because they're in there for safety reasons. There are ways to override and be able to provide a second prescription, but we are not overriding any existing rules for prescription medications, except for you need to provide that 30 days in hand, right? And there are some fill too soon edits that the pharmacy can use to make sure that they can do that. So, seeing here, over 50% of the King County jail population leaves within 0 to 3 days, with an average length of stay being 3 days. We have around 30 to 50 bookings releases a day. How do you recommend we approach ACA requirements with this in mind? I'm specifically thinking about assessing Medicaid eligibility, application, meds at release, and reentry health assessment. I'm not going to spend a lot of time in this particular webinar on the medication piece. You can see on here that there are some, minimum requirements that we have set forth, those SUD medications within 24 hours. And then, for that pharmacy piece, when that expectation is in place. What I would say for the reentry targeted case management is these are the minimum requirements, right? If you have an individual that is, releases within 2 business days and they're releasing before that reentry health assessment is required to be finished. So just really kind of my suggestion would be to look at this and don't read more into it than that's there. We've tried to set this up in a way that meets the requirement, yet takes into consideration those short turnaround stays. So completely acknowledging that the vast majority of individuals are turning around pretty quickly. And so that's why we built it this way, was to try to strike a balance between, what needs to be done and what are the current barriers that are in place. So, have the courts in Washington State received notification that this starts July 1st and given any guidelines? I worry that some judges or attorneys would ask that the defendant stay incarcerated until rTCM is set up and verified. I don't know the answer to that question. So we haven't got involved in, to my knowledge, of any, of what a court order would say. So I can't speak to that directly. We are approaching this from a medical standpoint and not, we completely understand that if somebody discharges unexpectedly, that you cannot hold them. And so those are things that we've taken into account here as well, especially when talking about, you've heard me talk a little bit about it with the medication. So the slides, I see that we provided that. Christine, I see we often have youth booked and released within 24 hours. What is required if custody less than 24 hours? Well, if they're in for less than 24 hours with rTCM, as you can see here per the short-term stay, there wouldn't be a requirement if they're in your facility less than 24 hours, right? So if within 48 hours that rTCM should be assigned, always encourage getting that done as quickly as possible, because then it gives that rTCM time to look at what is on their workload and what needs to be done. But if they're booked in custody less than 24 hours, as far as rTCM goes, there would not be a requirement there. There would be some other requirements for SUD treatment, right? Megan, oh, here's the reentry need to transition. Okay. I see, Megan, you didn't understand the response to the business day model here. I'm not sure. This is going to look different from facility to facility. What we've set is the minimum standards here. So by business day 3, that reentry health assessment needs to be, started and completed, and then by business day 4. So if somebody's booked on Saturday, business day 3 would be Monday, Tuesday, Wednesday, right? So that health assessment wouldn't even be due and required until Wednesday, with that care plan and coordination starting on Thursday in that case. So hopefully that's helpful. Rachel, anything I'm missing?
No, I don't see anything that you missed.
Anything I said that's wrong, please correct me if I said something wrong. Anything else? I'm sure a lot of you have heard me talk a lot up to this point, so. Okay, I'm not seeing any other questions. Emma, I guess I'll pass it back to you. I would say that, I worked in, I was a correctional officer before. I know this is a big lift. And the work that, the fact that you're in this meeting, or you're already engaged in this work, or you're going to engage in this work, or you're considering engaging in this work, it's fantastic. It's a big lift, and I know that. And many of my colleagues have also worked in corrections. So, these two, it's two different languages. And it's brand new, it's groundbreaking, it's new in the country. We are the second state that is engaged in this work, and in some cases, some of the stuff that we're doing is going to be first in the nation, right? So it's commendable that you're all doing this work, thinking about this work, or about to engage in this work. So I can't say that enough. When I worked in corrections, when medical staff came to me and I was a correctional officer, I didn't want to talk about medical stuff. I wanted medical staff to do medical stuff, right? And then I jumped to the dark side, became a nurse, and started to speak both languages. So This is great that you're all here, and fantastic that you're all embarking on this. So thank you.
All right. I think that's all for today then. So thank you, everybody. Really echo what Arthur said. And please feel free to send any follow-up questions to our inbox. All right.
Okay, thank you.
Thank you.